In this video, I'm going to demonstrate closed insertion and removal techniques for airway devices. The rationale is that containment is a much more effective strategy to prevent infection than PPE. I'm modelling the latest in cloth masks, not because I'm trying to protect myself, but so I can prevent contamination of my colleagues if I were to have the virus. I will not be discussing PPE in this video. If you're planning to use nasal prongs afterwards, the easiest thing to do is to put them on before induction. If you are planning to use this technique, you should make sure that you have some plan to cover the mouth and nose after you remove the airway device. Otherwise, you can put a Hudson mask on after you remove the airway device. We then perform long pre-oxygenation. I'm going to anaesthetise this patient and insert a laryngeal mask airway. I'm doing this because I believe the patient is COVID-19 negative. If I thought they were positive, I would intubate them. I'm going to give a sufficient dose of induction agent that I should be able to insert the mask without having to bag, mask, ventilate. Before I induce, I'm going to confirm with my assistant, are you ready? And I'll wait for his response.
Yes.
Before induction, I placed a disposable plastic drape over the patient's chest. I'm now going to induce the patient. Once I believe the patient is unconscious, I'm going to cover their face with the disposable plastic drape. I'm aiming to insert the laryngeal mask without bag, mask ventilation. If it becomes necessary, however, it's possible to perform bag, mask ventilation with your hands outside the drape. I'm now going to insert the laryngeal mask airway. First, I'm going to connect the airway directly to the breathing circuit. This is facilitated if the assistant supports the circuit during insertion. I'm going to test ventilate, and when I'm happy, I'll remove my face mask and place it in a sealed receptacle. At the end of the case, remove the eye tapes and the tape around the laryngeal mask without putting your hand under the drape. You'll note that I've pre-positioned the surgical mask as a sputum cover. If you do not have sufficient supply of surgical masks, you can improvise. When I'm happy that the patient is ready for removal of the laryngeal mask, I'll remove it and keep the drape over the face until I'm convinced the patient's not going to cough. I'm going to cover the mouth with my sputum cover, wrap the laryngeal mask completely in the drape and dispose in the clinical waste. Intubation is technically more difficult, but still possible. I'm going to connect the tube first. My assistant will hold the circuit for me. Once I've secured my laryngoscope blade and mask in a sealed container, I've taped the tube in. I now suggest inserting a bite block so that the patient doesn't bite on the tube at the end of the case. You'll notice that the distal end of the circuit is actually under the drape here and should be considered contaminated. This technique is designed to be used for universal precautions when you're performing urgent or semi-urgent cases in patients that you believe to be COVID negative.